Okay, we're going to go ahead and get started in the interest of time. Thanks for joining us. I'm Tim Anderson. I'm one of the senior research analysts at Bank of America. And this is a 25-minute fireside chat with Eli Lilly, which is one of the companies that I've covered for a long time, nearly 3 decades. And they've really been a consistent leader across the period in R&D in lots of disease areas. So we'll be talking today with Dr. David Hyman, who's Group Vice President, Chief Medical Officer. In this role, he works closely with all of the development leaders across therapeutic areas and the development business group to advance Lilly's portfolios of medicine. He also directly leads development in the oncology group. Previously, he served as Chief of Early Drug Development Service at Memorial Sloan Kettering. So we're going to focus the discussion mostly on obesity and diabetes, which probably doesn't surprise you. It's in the news a lot, and it's a major driver of what Eli Lilly's stock price has done over the last few years. And I thought we'd start by kind of exploring the current treatment paradigm, but a really intentional high-level question just to kick things off, which is, what are the most topical issues right now when you're thinking about patients being treated in obesity?
Yeah, well, first of all, thanks for having us. We always like to be here and appreciate the opportunity to talk about our research. So I think maybe we just touch on sort of the overall evolution of the space over the past couple of years. I think when we started working in this space, the first question was sort of like, do these medicines work? Do these medicines work durably? What is their safety? Just sort of like the basic questions when you enter a new therapeutic class. I think the past several years have really been focused on what are the hard outcomes associated with these therapies. So what are the actual medical conditions that are being improved in addition to the weight loss and other metabolic parameters that are improving with these medicines? You know, we and Novo have been big contributors to the science there in defining the conditions, some of which we understood were weight-related, some of which we only define through the clinical trials that we've run definitively as weight-related. I think that has, we'll continue to do that work. That, I think, has percolated pretty clearly into the medical community. I think people now understand these medicines are effective. Obviously, they come with some risks as well, which is important to understand, and that they improve many obesity-related health outcomes. Obviously, the other thing that's happened over the past several years is just improving the access to these medicines. Both their manufacture, their availability, coverage of these medicines. So these are like just sort of blocking and tackling moves we have to do if we're going to treat anywhere close to the number of patients that can benefit from these. So I think at a really high-level view, it's really been about medical evidence generation and then manufacturing enough of these medicines and getting patient covered so they don't have financial or access barriers to the medicines.
One of the things that has surprised me, and I think others, is when you look at the data on compliance on therapy, or really the persistence on therapy, how long patients are staying on these medicines, the data shows that by the 12-month mark, half or more patients are dropping off, which is absolutely surprising. So, you're a patient, you're looking in the mirror, you're seeing all this weight loss, you're feeling better in lots of ways, and patients go off therapy. So I almost feel like there's confounders in that data that probably say it's really not a real figure. But when you're talking about outcomes, right, you really need compliance to be there if you're thinking about cardiovascular event reduction, for example.
Yeah.
So what do you think's really going on with persistence on therapy, and where does that get to when we look forward over, the next couple of years, let's say?
Yeah, I think it's an important and it's an unanswered question. There's no chronic disease that I'm aware of where there's perfect persistence or compliance over decades of life. Obviously, like people, for a variety of reasons, come on and off medicines even when they continue to benefit from them. I also agree that the compliance or the persistence numbers that you're citing are highly confounded by a variety of factors. Supply has historically been a factor, not so much anymore. Financial coverage, out-of-pocket costs. So I don't think we've really seen where these numbers net out. I also think that if you define persistence on these medicines from first dose of the medicines to when patients discontinue them for the first time, we're sort of missing the bigger picture, which is, I'm sure we all have people in our lives that are on these medicines. And one of the things that I'm struck by is these medicines do more than lowers people's weight. People feel better, they start becoming more active, they make lifestyle modifications, they go to the gym, they change not only how much they eat, but the content of what they eat to lower glycemic index foods, more whole foods. And I think at a certain point, many of the people that I've, in my own personal life, so this is more of an anecdote than science, will say, like, I sort of wonder if I can get there on my own. Like, whether, like, is this really the medicine at this point, or was the medicine the thing that got me started, and now I can manage this on my own? And I understand that urge. And for some people, they can maintain a lot of the weight loss, and not for everyone. So I think when we think about persistence in this space and whether patients will benefit from the full compendium of what we're reading out in our clinical trials, I would urge us to look not just at like the persistence data that exists now, but almost like a dose intensity concept. Like, what percentage of the time over a 5-year period do patients spend on this medicine? I think over time, or do people spend on this medicine, that number will go up, not down. The experience of being on these medicines generally is viewed as positive.
Yeah, I mean, if I was still treating patients, if I got a patient to goal or they got to goal, I mean, it's not at all unreasonable. Take them off therapy, see what they can do through behavioral modifications.
Absolutely, yeah.
A question for you is, what percent of patients on GLP-1s can actually keep that weight loss off therapy? I have to imagine it's single-digit percent.
I think it depends on how you define the endpoint there. So I think that nearly everyone will regain some weight when they stop these medicines. That's almost universal. There will be a percentage of patients, it varies from sort of real-world study to real-world study, but don't quote me on the exact numbers, but figure like 10 to 20% of people will get substantial percentage of the weight they lost they'll be able to maintain. Many others will drift up over time and make a decision about whether they want to come back on the medicine. I think big picture, in any other chronic disease I'm aware of, we don't expect that once somebody reaches a goal that they'll be able to maintain that off medicines. We don't do that with blood pressure, we don't do that with lipid control medicines or diabetes medicines, and I think it's reasonable to expect largely similar outcomes here.
Yeah. So, feeding into persistence on therapy is tolerability, right? And like most drug categories, you don't get something for nothing. So there's, fairly high rates of nausea and vomiting. It usually starts early on or right after dosing, and then it gets better over time. I guess the question I have is, what can be done to improve that, or are we at a steady state? When I look at competitors or other compounds in development, a lot of times there are claims of differentiation. We're going to lower weight more, we're going to be more tolerable. And when I look at the data, it kind of makes me think, I guess I question that. So what can be done to improve tolerability, or are we at a steady state?
Yeah. Well, I think, first of all, we just talk for a little bit about what our clinical trial data show in terms of tolerability. Really, the most common adverse events, and obviously anyone considering this should speak to their physicians, are, as you mentioned, gastrointestinal related. Those tend to occur early when a patient begins a new dose of the medicine, and then as they become acclimated to that dose, you actually see the persistence of those adverse events, those gastrointestinal adverse events, decrease. You can sort of look at these as prevalence or incidence plots, and what you see is that for many, many patients, after they've been on a steady state of a dose for a while and they've acclimated to it, the rates of nausea and vomiting are not actually all that different than you see on the placebo arms of our clinical trials. So I don't want to give the impression there are not side effects or risks to our medicines, but actually it really is more of a titration phenomenon for the majority of patients. So I actually don't think most discontinuations of these medicines, and our data show this, in a patient that's been on the medicine for 6 months are not actually adverse event related. But there are things that we've done. I think one of them is we do now understand, I think, pretty clearly that our medicine, tirzepatide, which is sold under 2 different brand names, is a dual-acting medicine. It not only agonizes what everyone knows, GLP-1, but also a second gut hormone, GIP. And it's pretty clear that agonizing GIP is associated with improved tolerability. So I think there are profiles intrinsic to what the biology of the medicine targets that can be associated with a different adverse event profile. There are different classes of medicines as well. We've shown data, we'll show more data on our selective amylin agonist at Obesity Week in a couple of weeks. And that is associated with a different adverse event profile. And we do see in early clinical trial data sets different and lower rates of GI adverse events than what we've experienced with GLP-1s. So I think some of these are, it's sort of first principles. What is the target of these medicines? What do they agonize? That will have an impact. The PK profile of the medicine has an important impact. Is it a high peak to trough ratio? You really want as much flat as possible PK as you can get with these medicines. So all those factors go into play.
A big outstanding question, I think, increasingly is weight maintenance following this induction phase, and what can be done. Does anything need to be done differently? Can it be done differently? And I know that you guys are exploring a few different approaches. So among the different approaches, you could look at a lower dose versus what you use in induction. Maybe you could use something like an oral, and we'll get to your oral orforglipron in a moment. Maybe there's orthogonal mechanisms that you can switch to.
Yeah.
So where do you see this playing out? My guess is it's too early to know, but what do we know at this point?
Yeah, I think it's just we're saying there are very few areas in medicine where the number of patients that are impacted are this large, obviously, and so I actually don't think there's going to be a single monolithic approach here. And actually, what I'm most struck by as I speak to physicians and patients and attend conferences in this space is how individualized and customized and sort of to the patient's individual needs, profiles, goals, these things are. I think broadly speaking, we've heard a couple of categories. One is people are feeling great on the medicine. They want to continue it for as long as they can. That's great. There's another group of people who say, well, I've achieved the goal. Can I get away with less medicine? It's actually often not, when you speak to them, driven by any particular adverse event they're having. They just have this view that if I'm going to be on this medicine for a long time, I want to be on what's sort of the minimally efficacious dose for me. That's fine, and so we're studying that in clinical trials. We have 2 clinical trials we're running. We're basically randomizing patients who achieve their stable weight to one of the higher doses of the medicine that got them there versus a lower dose, and we'll be able to describe whether, what the impacts are. Those data should come next year for tirzepatide. And then the other approach that you alluded to is, are there different routes of administration? Is it, would a patient want to move from an injectable platform to an oral platform? And we have a medicine, orforglipron, that we've read out, and I'm sure we'll talk about today. Then we're studying that as well, and we'll have the data year-end or beginning of next year on that approach. I think it's going to be very, very customized to individuals. I don't think there's going to be one size fits all. But I think one of the things that we've committed to is generating the data to guide these decisions and these conversations that physicians can have with their patients.
Let's talk about safety. So, and different from tolerability, you hear a fair amount about lean mass preservation, and some companies that say it's a problem with the GLP-1s. When I talk to prescribers here and elsewhere, you commonly hear, I don't really ever see anyone who has a lean mass issue. And I think it's part and parcel. When you're losing fatty tissue, you're losing some lean mass. So I guess the question is this concern about lean mass loss real? And you want to talk about the programs you guys have underway that might address that?
Yeah, so I think there's, GLP-1s, dual agonists like tirzepatide or amylin drugs all work through sort of a caloric restriction mechanism. Whenever you're consuming less calories and you have a negative caloric balance, you lose fat and lean body mass. That happens even if you're doing that through diet and exercise. And so some degree of lean body mass is sort of part and parcel for any of these pharmacologic or non-pharmacologic approaches to weight loss. Obviously, we think it's important that patients exercise on our medicine. That's just a general good health measure. But I think both in our clinical trials, and actually the FDA has spoken quite explicitly on this as well, that they don't view the lean body mass loss as a medical problem. And in fact, when you look at our outcome studies that we run with these medicines, you don't see any evidence of loss of function in the average patient. If anything, you see improvement. So in our heart failure study, people one of the parameters that was improved the most was the 6-minute walk test, the ability for people to traverse a flat distance. That was improved in our preserved ejection fraction heart failure study. And you see this, I think the other way to think about this is the outcome studies that have been run in diabetes and non-diabetes. You see people having fewer major cardiovascular events. There's no evidence that this is leading to disability. Actually, when people come off our medicine, this is less publicized. And when they start regaining weight, they actually regain both lean body mass and adipose tissue. So you actually see that when people come off our medicines and regain weight. I should also mention that people that are obese at baseline actually generally have higher lean body mass due to the mechanical effort of maintaining their weight. So you're alluding to other approaches. We have a medicine that we purchased, a company we purchased, Versanis, that had a medicine, bimagrumab. This is an activin receptor antibody inhibitor. This is a medicine that can build lean body mass. We're studying this in combination with tirzepatide to understand whether, not that we think tirzepatide has a problem, but can we further improve upon healthcare outcomes with combinations of these medicines. And when we have more data to share in that regard, we'll share it. But I think we're really focused on healthcare outcomes, not sort of lean body mass as a number disconnected from healthcare outcomes.
Promising new indications for the GLP-1. So most people think of these as obesity and diabetes drugs. We know, of course, they lead to heart attack reduction, they improve sleep apnea, they lead to better joint health. But there's some other stuff under study. I think you guys are running various phase 2 trials in immunology indications as an example.
Yep.
We know that Novo Nordisk, which is your lone competitor at the moment, is running 2 phase 3 trials in Alzheimer's disease, and those should report out before the end of the year. And Lilly's choosing not to pursue Alzheimer's disease in that. And we just had an Alzheimer's panel, and they I guess there's fingers crossed on that, how those will read out. But do you want to talk about some of these earlier uses and what you're seeing and what the data is showing thus far?
Yeah, I think I would divide the world into sort of 3 categories. There's a bunch of conditions that we know from the bariatric surgery literature are weight-related. So obstructive sleep apnea, for example, clearly related to ectopic fat. Osteoarthritis of the knee, we just know from epidemiologic studies, are associated with obesity. So there's those set of conditions. I think we've gone about just methodically studying, okay, these are weight-related medical conditions. If we improve a patient's weight, do we improve those conditions? That's pretty straightforward. I think we have a lot of those studies in flight. There's a separate set of conditions which are related to sort of metabolic disease, insulin resistance, dyslipidemias, things like that. These are the MACE outcomes that you referred to, or major cardiovascular outcomes, adverse events. I think there's a third category of not weight-related, and maybe not even in patients exclusively that are overweight or obese, where there may be a pharmacologic impact of GLP-1s or dual agonists like tirzepatide. You've mentioned some of those. Novo's studying this in Alzheimer's disease. Those EVOKE studies, I think, will be extremely interesting readouts later this year. In chronic immunologic diseases, we now understand that patients that are overweight or obese have less robust outcomes to biologics, for example. So we're studying tirzepatide in combination with our IL-23p19 inhibitor mirikizumab and our IL-17 inhibitor Taltz in inflammatory bowel disease and psoriatic diseases. So we'll see whether those combinations offer improvements over the biologic therapy alone. I think there are a couple other areas that are, again, outside of, and Alzheimer's is a prototypic example of this, outside of just like patients that we currently treat with these agents that may benefit through these other pleiotropic mechanisms. So we're interested in studying them. Another area that's gotten a lot of press, we have some phase 2 studies in substance use disorder. We'll have others that we announce as data sort of come forth. A lot of these are coming from real-world data sets. So there's now millions of people on these medicines. We can learn in large data sets of hundreds of thousands or millions of people about health outcome benefits, and then we can run prospective clinical trials to define those in a more rigorous way. So we're trying to learn the full complement of benefits from these medicines. I will say that this class of medicines, to my knowledge, has never had a negative phase 3 study ever. I think as we go a little bit into the more exploratory space, I think we should be prepared to have some negative studies. But I would rather try that and fully define the healthcare benefits than sort of be cautious with a class of medicines that's yielding so many unexpected benefits.
Let's pivot to orforglipron. This is your oral GLP-1. It's been in the minds of investors a lot, and we've seen data sets. I think scientifically it certainly feels de-risked. I think the question for investors is, where does this fit in the armamentarium of obesity drugs? So what's the positioning of this? The way I look at it, tell me if I'm wrong, I think the workhorse product's probably going to be tirzepatide, injectable, weekly. You don't even see and feel the needle. And an oral is a nice addition to that, but it's probably not going to be the main product.
Yeah, so let me just take a step back and then I'll try to come to your question. I know we have limited time, but so we talked a lot about tirzepatide. That's our weekly injectable product that hits two receptors, GLP-1 and GIP. Orforglipron is a non-peptide, so this is a true like small molecule medicine that we can synthesize in like metric ton qualities through like traditional chemical reactions. In a pill form, this is a pill that's a daily oral with a 24-hour half-life. It doesn't require cold chain refrigeration. And so the idea with this medicine was, GLP-1 monoagonism is a very effective modality. Can we turn that into like a almost infinitely scalable pill form, non-cold chain? You don't have food and water restrictions in how you take these medicines that could be scaled not only in the US but globally. I think the short answer to your question is a couple-fold. One is that I don't think we really know. I think one of the things that we've learned is that you have to be humble in this space. When we obviously are putting like a lot of concrete in the ground and spending a lot of CapEx to build facilities to make this really excellent auto-injector device that we are very proud of. When we did that, not realizing, and it's a great product and it's the best presentation of our medicine, but not realizing that actually like a vial format would be acceptable to a lot of patients, and actually like we have almost as many patients starting each week on a vial where they draw up the medicine, a single-use vial, and inject it, versus the auto-injector platform. I don't think anybody would have predicted that a priori. Similarly, we've never had an effective daily oral therapy for chronic weight management. So I think we should just sort of recognize that we don't know the full sort of demand profile of that medicine. I'll also mention it's an excellent diabetes medicine. It's could be the most effective oral diabetes medicine ever. That's an obviously covered market. So I think there's a lot of opportunity in the US. Ex-US, and you've also alluded to ideas like maintenance and things like that. I think ex-US, we're really only like barely scratching the surface of the ability to supply the world with our injectable cold chain products. And so really, ex-US, I think there's like huge amount of potential demand for these medicines as well. And again, we can scale to meet that demand given the platform of the medicine.
In the last couple of minutes, let's talk about your amylin agonist. So your compound is called eloralintide, and there's a few of these in development now. There's one amylin product that's in phase 3, which is from Novo Nordisk. So lots of promises being made about this class by different stakeholders. And I'm trying to think through, based on what we know, the best positioning. And like I asked with orforglipron, how is this going to interface with the GLP-1s?
Yep.
Is this a category that's likely to be used after a GLP-1, in combination with a GLP-1, ahead of a GLP-1? What do you think?
Well, I think it could be a little bit of yes to all of them. So just a little bit of level setting here. Amylin is another clinically validated target for weight loss. The vast majority of the amylin agonists out there actually agonize two receptors, amylin and calcitonin. Eloralintide is the most advanced, to our knowledge, selective amylin agonist. We'll, as I mentioned, be showing some data at Obesity Week with that product. We think actually that we think the product shows that it's actually amylin that's driving the weight loss profile, and a more selective inhibitor can be more efficacious with fewer side effects. So that's what we have to prove in our randomized clinical trials. I think what we're seeing in broad strokes is a medicine that can be competitive in a weight loss profile to GLP-1s, with a different side effect profile like we spoke about, potential for less nausea and vomiting. Although I will say that you have to really be cautious in interpreting safety data sets of early phase clinical trials, and these are not very far from like medical claims. Obviously, we need to prove these things. I think there's a couple of uses. I think, and again, this is going to be a highly segmented market over time. So there'll be some people who start on GLP-1, GIP agonists like tirzepatide, who don't hit their target weight profile and want to add this medicine on. There'll be some patients who had a bad experience, and even if it's only 15% of patients, 15% of a large number is a very large number. And then I think there'll be maybe some patients that just elect to sequence through these medicines just like any chronic disease space, even when they don't, quote, fail or are intolerant of one. So I think there's a lot of potential uses. I think what we're not thinking is every patient's treatment is going to need an amylin that's going to replace the backbone of GLP-1 plus agents.
David, thanks for coming. Thanks to the rest of the Eli Lilly crew for coming to the forum today.
Thank you for having us.